Good evening, everyone, and welcome to TriVersity Talk. I am Stephen Bloomer-Teague.
And I am Wendy Stewart Kaplan, and happy Sunday. Thank you for joining us tonight. We have a great show.
Absolutely. Have a terrific show. But before we get into that, whether you're on Facebook or YouTube, if you could give us a like, a follow, or subscribe, or if you could give us a thumbs up, however you're handling your social media in terms of likes and subscribes, we would definitely appreciate if you give us those. That helps us get this show out there, and we think it's a very informative show and would like as many people to see it as possible.
And people have been telling us it's very informative, it's entertaining, educational. So please share it with your friends.
Well, but what I will say is, I've had a very serious dilemma with this show. Unfortunately, it has become increasingly difficult for me to find what I call, quote, TV shirts, because I don't have a very robust wardrobe. And so keeping it fresh every week's been tough. But it is like the wardrobe gods came to me because we are in Transgender Awareness Week. And I happened to find in my wardrobe a pink, blue, and white shirt. So
and you have your button on your Transgender
and I have my
Awareness button.
Transgender Awareness button. And this is a very important week to a very important community. And this week caps off on Friday, November 20th, with Transgender Day of Remembrance. This is where we remember and honor those who lost their lives to anti-trans violence this year. TriVersity, as we have for the past several years, is hosting a Transgender Day of Remembrance Vigil. This will take place outside at Good Shepherd Episcopal Church at 7 p.m.
Friday.
Friday. We will stay socially distanced. We will wear our mask the whole time. But we would like to have a little service to commemorate this
Absolutely.
This day. And I think that's all I have for now. So, Wendy, would you like to introduce our guest?
Well, as World AIDS Day approaches, we have not just one, but two special guests this week. We have Mayor Sean Strub, the mayor of Milford, and Dr. Joshua Vernatter, or as we're going to call him tonight, Dr. Joshua. I asked how he wants to be called, and he said that that was okay for him. And we're going to have an incredible conversation. As many of you know, Sean wrote the book, Body Counts, and he's been living with HIV for more than 35 years. He is also the founder of Pause Magazine, and he is the first openly HIV person who held and ran for federal office in the U.S. And let's see, we have so many more. Sean, this guy he's just done everything.
He put a condom on Jesse Helms' house. I mean,
he did, and that's what he's going to be.
How that is not in his bio, I will never know.
That's right, and everybody remembers that. But he also serves as the executive director of the Sero Project. That's very important. It's a U.S.-based national network of people living with HIV that's best known for its work combating HIV criminalization. And Sean has a short film connected with that, HIV is Not a Crime. And he is the first person to introduce HIV criminalization to audiences and advocates around the world. And there's another fantastic film, which we loved it. It's called My Friend the Mayor. And that is available on many different platforms, but we're also going to put it up on our screen tonight. So you'll be able to find out how you can watch that film.
Absolutely.
Dr. Joshua is an infectious disease doctor, and he is an MD at Albert Einstein College Medicine in the Bronx, my home place before I came to Milford. He completed his residency at Long Island Jewish Medical Center and an infectious disease fellowship at Montefiore Hospital, or as some people call it, Montefiore. He is currently practicing in Middletown, and we are so blessed to have him in our area. He treats infectious disease with a focus on HIV care, and we want to give you all a big welcome. Thank you for being with us tonight.
Thank you.
So, Sean, for people that I always think, because I know you for forever, right, from back in the 80s, but I realize, and I have had to become cognizant, not everybody does. Can you briefly just give us a just quick little background about you?
Oh, gosh. Okay. Well, it all began on a warm May day in Iowa in 1958. I moved to New York in the late 1970s and became very engaged in LGBT politics and as well as Democratic Party politics. But as the epidemic hit, it kind of hijacked my life and became the focus of my advocacy and really just about everything in my life. And I was involved with the People with AIDS Coalition in New York from like 1983. I was diagnosed when the test came out in 85, although looking at my medical records, I think I was probably acquired HIV in 1980. So this is around my 40th anniversary. And then I was very active with ACT UP, co-chaired the fundraising committee where we did these spectacular actions like a gigantic condom over Jesse Helms's house, which that video is on YouTube, actually. It's quite spectacular. And actions at St. Patrick's Cathedral and elsewhere. And I started Pause magazine in 1994, in large part because while I was certainly surrounded by lots of death and dying and suffering, I personally, my viral load, was in the millions. My CD4 count got down to 1. I was covered with, the red spots for people who've seen the movie in Philadelphia, Kaposi sarcoma all over my body and in my lungs, and weighed about 40 pounds less than I weigh today, which is like 163 pounds, and I'm 6'1". So I came really close to death. So while I was surrounded by that, I also felt incredible vitality. People who were leading their lives and pursuing their careers and raising their children and making art and writing and doing all the things that a full life involves, even while they were managing an illness that at that time was most likely to kill them. And that's what I really wanted to reflect in Pause. I was living in New York where there were a lot of people around. There's a great community. I could go to, ACT UP meetings or whatever, be around other people with HIV, which is where I learned. But lots of people were more isolated and didn't have that proximity to support and information and so on. So that's when I started Pause. So that's a little bit about me. And then when my health got better, I bought a weekend place in Milford. My life was different. I wanted to be in the woods and have a nice life, and ended up getting kind of hyper involved here in Milford, restoring buildings and doing things. And now I'm the mayor. And by the way, my friend the mayor, it's on Amazon Prime. So anyone who gets Amazon Prime can stream it.
Great! Yeah, it was a great film. So
And fair warning, everyone, I typically put in the comments all the different websites that I think might be pertinent to the show or pertinent to our guests. And there are a lot of different comments that I'll kind of put on the screen here, but you can scroll, find those. There's hyperlinks. Click on those to find anything that we talk about tonight.
Or you can reach out to us, old school comments on our Facebook page. Let us know what you need and we will get back to you. It's funny, Sean, one of the words that you used about starting Pause, you realize the isolation that came with having AIDS. And I was certainly very involved in those days. So let's fast forward to now, because that word isolation is very important. Dr. Joshua, you're over in Middletown. I would think, and thank you for being in our area, I would think one of the biggest challenges, and I remember this from the 80s, finding really great doctors, right? That were not putting people on AZT, which everybody died from. There were doctors that had other drugs, right? So if someone is in a rural area, it's very challenging to find a doctor that can really help them. So Dr. Joshua, what brought you to the Middletown area?
After I trained in the Bronx, I was working in Westchester County, and there was a job opening at the hospital here locally, in which sounded like a great opportunity, and I took it. And I'm not there any longer, but I stayed in the area and plan to. settled down here. And
That's
I can't say that I was looking for Middletown because I didn't know anything about Middletown.
Right.
But it was an opening, and here I am.
I'm from small town South Carolina.
That's
So
right.
if I had ever imagined moving to Milford, Pennsylvania, it wouldn't have been on my
Right, that
list.
wasn't in your
But,
cards.
you know, fate brought me here, and maybe the same way that fate brought you here.
Sure.
And we're glad that you're here.
So
I was raised in West Virginia, so it wasn't a turnoff to move out here.
Right. That's well put. It wasn't a turnoff. So, Sean, how did you and Dr. Joshua find each other?
Sure. So, and that was really why I was so interested in doing this program, because, you know, I've been in Pike County now almost 25 years. And, you know, the first few years, all of my healthcare was in New York. Mm-hmm. And as I started spending more time out here, I was really looking to, you know, get healthcare out here. And I tried several different doctors who were nice, who were committed, who were great doctors, but they didn't have the expertise in HIV. And I don't mean the expertise of being able to, read the articles and say, oh, this is what you're supposed to do with this set of clinical symptoms. But I mean the expertise of really listening to people with HIV and learning from them as much as you're teaching them. And I don't remember how I first came to Dr. Vernatter. Maybe he remembers. Was it a referral from someone?
I think so, but I don't remember who.
And I have to tell you, I'm, around HIV treatment, I'm kind of act like a know-it-all, right? I've been through all the drugs, all the stuff, the AZT stuff. It didn't kill everybody, Wendy, but it did kill some. And most physicians I meet today who did not go through all that at that time, they're taught, they practice what they were taught, and they don't have as much kind of like, I don't know, sort of independent look at this stuff, or understand and put the effort into individualizing treatment. So I tend to come to a new doctor with not quite a chip on my shoulder, but with plenty of skepticism. Right. And I was so impressed that Dr. Vernatter, the thoroughness of his questions, and really like not listening just to what I said, but sort of through I said to, maybe what I wasn't saying. And when we discussed, well, first of all, we discussed treatment options. He never told me this is what you'll do. He says, well, and it was always like options. You could do this. Some people might want to do this, but I recommend this because of this reason. And that dialogue is just so important to me. And so over the years, I've referred several friends to him, and every single one of them is friends with HIV who live in the area, has been really, really, really pleased. So, I think of the people around here who have HIV, and, many of them may, necessarily be keeping it a secret, maybe, dealing with the stigma, may or may not be getting really first quality healthcare around it. I wanted them to know that we have a doctor in the Upper Delaware River region and the Hudson River Valley region who is as fine a clinician as I've ever been fortunate to experience in 40 years of living with HIV, and hundreds, thousands of doctor visits. I don't know how many. So that's what prompted me, is to let people know that there's somebody here who's expert and empathetic and interested, wants HIV patients. I'll tell you that one of the first doctors I saw here was, and I won't obviously name who it is, although part of me would like to. And it was for, I forget what I went in for, but it was for something else. I think it was for an injury, a sprain or something. And, you have to fill out all the healthcare stuff and this and that and whatever. And I went HIV positive. And, you go into the room, and of course he hadn't looked at it before. So he's got the clipboard and he's going, HIV? How on earth did you get that?
Oh my God.
Oh, heaven help me.
Really? He said, how on earth did you get that?
Oh my God.
And I'm not one for, going for the shock or the vulgarity, but, my response was, oh, the usual way, butt fucking.
And good for you.
He turned right red, and his reaction. I knew this was not going to be a long doctor-patient relationship.
You knew you'd never be back again.
But I know someone who had a dental emergency. It wasn't right here, but it could have been, and it was traveling and needed to see a dentist. And found it where you describe the thing. Go there, fill out the thing. Goes back to the receptionist. Takes it into the doctor. A long time. Now there's nobody else in the waiting room. We didn't see any other patients. Finally asked what's going on. Oh, he's on a call. Finally, we come in. Oh, you sit in this room, and the friend who was with was put in the dental chair. The dentist came to the door of the room and was all masked. This was a few years ago, not masked for COVID. Mm-hmm. And never shook our hands, never touched us, just asked questions and prescribed pain medication until we could get to the bigger city where we were going. And on the one hand, if he's not informed, you can't blame him for being afraid. Fear comes from ignorance. The stigma can also come from bias and from intolerance and so on. But I think of the people who experience that all the time in getting healthcare, the varying gradations of judgment and fear and bias and ignorance.
I agree.
It feeds into a stigma that makes it much more difficult for a person living with HIV to competently access their care and take care of themselves and build the support around themselves to be able to cope with such a stigmatized diagnosis. Even though today someone diagnosed has every reason to expect to live a normal lifespan, the medical side we've made astonishing progress. Yet I'm telling you, as somebody who's lived with HIV for 40 years, HIV-related stigma has never been worse. And there's no pill to combat stigma.
It's so awful to hear that.
Well, and the reason I don't mean to do a monologue here, but I want to explain why I say that HIV stigma, hasn't been worse, because lots of people. Well, Wendy, you remember when you had to wear a spacesuit to visit someone in the hospital, and they'd put the tray of food at the door. Underneath the door.
And yeah, you're right. You had
people wouldn't go to restaurants if they knew there was a gay waiter, and all that kind of stuff that now we know was sort of ridiculous. And that's certainly, related to stigma, but that fundamentally is fear of casual contagion. And most people know better today that, you're not going to get it by shaking hands with somebody or sharing a water glass or a toilet seat or, whatever like that. But stigma, as experienced by the stigmatized, isn't so much about fear of casual contagion. It's about people prejudging you, making a judgment about you before they even know you, before they hear words coming out of your mouth, and particularly moral judgment. It is about marginalizing people. And it's very much about a self-stigmatization and internalized stigma. And by those measures, it's definitely worse today.
Well, it's interesting, Sean, because I think where you have the upper hand, and it had to be challenging for you with certain doctors, 40 years of living with AIDS. I'm sorry, but in that amount of time, you have to know more than a lot of the doctors.
Well, I lived a lot of them that treated me.
Right. And you've been through, experimental things. You've been through everything, right? So, Dr. Joshua, I'm going to toss the ball in your court now. You're young, and when back in the 80s when we were going through this, it was a bloodbath. It was awful. We all lost so many friends, and it's particularly impressive to me that you were a little kid then, right?
Absolutely, yeah.
Right. What made you in your medical choice to become a doctor, to become an infectious disease doctor? Why that choice?
It's not a direct path. I think I had an inkling going into medical school that I wanted to do infectious diseases, but I think the kind of infectious diseases I had in mind, it was more the mystery diagnosis kind of thing.
Okay.
but when I got into training, there's something about HIV care that the rest of the infectious disease world kind of lacks, and that's the continuity and the longitudinal aspect of care. And I think in HIV care, you get to know people more, who they are and where they're coming from, maybe more than if I'm treating a tick-borne infection. I think that's kind of what appealed to me about HIV care specifically. And it is, you mentioned, yeah, absolutely. I was a kid, and when the epidemic started, I was really too young to even know about it. But by the time I was old enough to hear about it, all you heard was kind of how everybody died, and then I guess that makes it more poignant that no, actually everybody didn't die, and in fact we're at a point where a lot of people, most people living with HIV are thriving, and that's sort of special. That's that says to me that this is an area in medicine where we have an opportunity to make a real impact. Maybe more than most of medicine.
Dr. Vernatter, you remember the first person with HIV you treated, and like how many people with HIV have you treated over the years?
Well, so to answer the first question, my first encounter with the person with HIV was during residency. It was a hospitalized patient, not someone who was my long-term patient. So I didn't really have any long-term patients until fellowship. So that was only 10 years ago. I'm a rookie. I've treated, I'm going to estimate about 400 patients with HIV, which is nothing compared to the people that I learned from, who of course were there through the olden days, I'll say.
It's funny though, I think it speaks volumes, because we're talking about trust here, right, Sean? And that you trust Dr. Vernatter. You totally trust him.
So, Dr. Joshua, I have to ask, because Sean talked about some amazing qualities you have in terms of your empathy and, really talking to your patients about treatment options. Is this something you're trained with in medical school, or did you acquire those skills elsewhere? Where can doctor go to learn about empathy and learn about good bedside manner?
So I think it is something that they're talking about in medical school now, but I don't think you really learn it from talking about it. I give credit to people who mentored me in fellowship. Some of the people who I worked with Carol Harris, who was she was one of the early docs in HIV care in the Bronx, and she is a saint. She's still there at Jacobi, as far as I know, working. But I think seeing it modeled and seeing that and just sort of how to approach it and how to think about it and how to connect with people, you have to see it. You can talk about it, but And I think Sean flatters me a little bit.
His arguments don't come easy, so please take them.
Well, you've also got to consider it in context, because I could talk a long time about really awful doctor experiences.
I'm sure.
So locally, I mean, you must draw people from some distance who come to see you because you specialize. Do you have, how large an area do people come from to see you in Middletown?
That's a tough question. I think we get some people from sort of northwestern New Jersey and northeastern Pennsylvania, and up as far as kind of into the Adirondack region. It's a pretty wide area. I mean, there is, if you go over east of the river, there's a lot more available in terms of HIV care.
Yeah.
But on this side of the river, there's not a whole lot.
Now, wait a minute. The river you're talking about is the Hudson or the Delaware?
Delaware?
On this side of the Hudson, right.
Oh, I thought
East of the Hudson, there's a lot. We're thinking the Delaware River, so you're on the west of the
If you're
river.
talking about the Delaware, there's not a whole lot on either side.
No, that's the.
doesn't matter what river you're
and there is the problem in a nutshell.
Right. So how do you, this is something that I think about a lot. I meet more and more young people, and I'm talking people in their 20s, right, that have this background that AIDS came about in the 80s. They know what happened, and yet they have unprotected sex. They take PrEP. They don't think that this can happen to them. Sean, do you find that you have to talk to people like that, and how do you get them to see reason?
Well, I don't know. I mean, when people are young, they, frequently make decisions they regret later. And,
Sure.
I tend to think it's really more about empowering people around their sexual health, more generally.
Yeah.
I sometimes worry that we almost fetishize on this one sexually transmitted infection and at the exclusion of others that can cause all sorts of problems, as well as make one much more susceptible to acquiring HIV. And I think this begins, at home and in the schools. If we had, really, really good age-appropriate sexual health education in schools, and that can start very young, it can start in elementary school. What's age appropriate? So that we're really raising people to be conscious of their bodies and conscious about taking that, responsibility and feeling supported and empowered in that. We'll have better health outcomes, and people will be, shaming doesn't work. Wagging a finger at somebody and saying, I'm of a generation, right, where, you want to talk about the old days and you tell these horrific stories. And, well, you know what? No one wants to hear about grandpa's stories from the war. I mean, they're not interested. It just turns people off. So you have to talk about, you have to make it relevant today and make it without judgment, what you're sharing, and really focus on risk reduction strategies as well, which people frequently aren't even, kind of familiar with the concept, let alone know specifically how they can reduce risk. And make healthcare accessible.
Oh, yeah.
Here in Pike County, so many people don't have healthcare. So many people, we have an economy and a political and government policy that does not make it easy for people to get healthcare. And if people can't get quality healthcare, they're much more likely to have healthcare problems.
Right.
So Sean, you mentioned that in this area, that there are people that, don't have health care. What do they do if they're HIV positive? What are their options?
And that is a very good question. it kind of depends what the specific challenge is. But Pennsylvania, New York State, and New Jersey all have very good AIDS drug assistance programs. So they are able to access the treatment to suppress the virus. And there are clinics. There's a great place in Scranton, and I'm sorry I can't remember the name of it now, but I've been there and I've spoken there. They're wonderful people who run it. Of course, there's facilities in the city. But if somebody's having an acute situation, with some opportunistic infection, they have to go to an emergency room and hope that they'll get seen.
Wow. I was thinking about what we were saying about education. Have you in Pike County been asked to speak anywhere, Sean? In any of the schools or middle schools or high schools?
A few years ago, I forget what they called it. It wasn't it wasn't a GLSEN group. It was maybe their diversity group or something. Had me come and speak kind of generally about life as an activist and so on. And I always try to get some stuff in there around prevention strategies and PrEP and PEP as well. Talk to the young kids coming to the center, to TriVersity Center. Probably the awareness of PrEP is pretty high, I would guess. Now, the number of them taking it or not, that's another matter. But I'll bet very few of them know about post-exposure prophylaxis. And post-exposure prophylaxis is a very effective way. It's sort of like a morning after pill, that if somebody, if a condom breaks or they had too much to drink or whatever, and they did something they regret and they realize they put themselves at risk, well, they've got, 2, maybe 3 days to get on treatment that they take for about a month. And it's, well over 95% effective at preventing transmission. So, that's an emergency. I think in New York State now, I think I knew some people working on this, that
Free
emergency rooms have to provide PrEP free of charge, PEP free of charge. So if somebody comes in and said, hey, this happened, and maybe it was a partner, you don't know their status or not, or maybe you knew, or this happened, they go through the questions, and if appropriate, they put them on PEP, post-exposure prophylaxis, right there. You take the first pill right there. And the sooner you can go on that after the exposure, the more effective at treating. And this is not the rest of your sexually active life like PrEP is. This is for 30 days. And it probably reaches 90% efficacy in 10 or 12 days.
Yeah.
How the hell have I not heard of this? I mean, this is crazy. I mean, yeah.
Well, yeah, that's a good point. We're in it knee deep. I had heard about PEP, but not a lot, honestly. Every single thing you said right now, I wish I could tape it and just put it out there as a public service announcement, because I can guarantee you there's so many young people that have no idea and are being exposed. So
what you could do is the TriVersity Center could create, I've always wanted to create little PEP starter kits, right? So you had 2 or 3 days of it. So if something happens, you can start right then. And then on Monday morning, you can get to a doctor or clinic and see if you really need to keep taking it or not. But you could also just do a little card that says, if you think you might have been exposed to HIV, this is where you go. This is what you ask for. This is what you can do. And, back when there were gay bars, which there hardly are anymore. I guess there's some.
Before the pandemic.
Okay. But, stuff like this should be, available. It should be at the, the student counselor's office and the health services at the schools. It should be, I used to on campuses a few years ago, speaking a lot on college campuses, and I ended up making the administrators mad at me because, I'd have a group of college kids and they're talking about this. I'm talking about PEP. I remember one in particular, and whose reaction was like, "You're deceiving." And he was, 18 years old and was kind of a pretty smart kid, studying being microbiology. He says, "I'm a proud young gay man. I want to be a microbiologist. I read everything about how the hell did I not know about PEP? Why haven't they told me about PEP?" And he was so exercised about it and was so smart that we got him a little grant from Broadway Cares, and he started, I think it's called pep411.com. It's now been merged into something else, where you could go in and type in your zip code. It would tell you somewhere nearby to get PEP. And that led to discovering that a lot of emergency rooms didn't know anything about it. The treaters didn't know anything about it or didn't think it was very important. So there's been kind of an effort around that. But, with PrEP, that people take for an extended period of time. So there's a lot of money to be made on PrEP, right?
Yeah.
I mean, there's a lot made on PrEP. PEP is 30 days of treatment. So that's the most amount of med you take.
That could change.
So there's not the resources behind getting PEP known. But what I was going to say, what I did on campus is they started, what can we do about it? And I can say, well, the first thing you can do is go to your student health service and ask them if they offer PEP. And of course, almost none of them did. And in all sorts of campuses, little groups of 2 or 3, or the gay student group, or the whatever organized, and got student health services to offer PEP. And and for government leaders and funders and public health departments, the economics are so compelling. What you save by preventing one new HIV transmission is dramatic compared to the cost of occasionally providing 30-day treatment to people to keep them from seroconverting. I'm sure Dr. Vernatter's office would provide PEP. I don't know if you've ever been
absolutely.
Well, you're in the hot seat now.
Absolutely, and I agree with you. This is something that is absolutely underutilized, and there's not enough awareness around, and I would venture to say there's not enough awareness even in the medical community around. But absolutely, would if we'd be more than happy to help anyone who finds himself in need of some post-exposure prophylaxis.
That makes me feel both better and worse that people in the medical community don't know about it. That makes me feel less bad that I didn't know, but also really scared that other medical professionals.
Put Dr. Vernatter's phone number on those cards you distribute. Need PEP? We should find out. I think in New York State, I think that emergency rooms will provide a course of it for free if you present an emergency room and meet the criteria. Sometimes people, they over exaggerate, or not exaggerate. They misunderstand whether they were really at risk or not, right? I made out with this guy and we, really kissed deep, and could I get HIV? I want PEP. No, that's probably not really a risk. Right. So they kind of go through and they ask those questions, and then if the person qualifies, then they get it. And very frequently, it's preventing somebody from having a lifelong and life-changing chronic viral infection.
Right, and it seems like such a little thing. It's such a little thing.
Absolutely. I mean,
so, Dr. Joshua, being that you're involved in infectious disease and you probably go to a lot of conferences, what's the future of treatments, if you can discuss them here?
Oh, well, okay. Well, it's hard to say what the future is, down the line. There's always been sort of this push for a cure, and I think most people believe that that's eventually what will happen. But I think there are a lot of things coming up in the more immediate future. This year, there hasn't been a whole lot, but we do actually have this year a new class of HIV drugs for the first time in many years. This is fostemsavir or Rukobia, which really is at this point just for people who have extensive experience with HIV treatment and probably resistance to some of the other medications. That's just out this year, and we're expecting very soon the long-acting injectable, which will be a monthly injection for treatment of 2 drugs, cabotegravir and rilpivirine. And I think that will be something interesting option for a lot of people living with HIV who maybe don't like taking a daily pill or frequently forget to take a pill. You get a shot once a month, and
easy.
That's it. interestingly enough, this also may be the basis a little bit further down the line for a new PrEP regimen, which would involve an injection of cabotegravir maybe every 2 months. We're not quite as close to that becoming to that reaching the market. But
they're working on something like that, which is
right.
really interesting.
And the monthly injection for treatment is already approved in Canada, so we would anticipate that here very soon. And then there are a couple of other new drugs in development that are new classes. There's a capsid inhibitor that's being worked on, and an antibody-based treatment that's being worked on that probably will be out not this year, but this year's running out quickly. So those are things that are coming soon, and we'll kind of have to evaluate what's the particular niche for each of these as they come out.
What do you mean by niche? Tell me what you mean by that.
Sure. So every time we have a new treatment for HIV, it's not necessarily going to replace whatever our state of the art was prior to that. It may be something that will be better for certain subsets of people, not for everybody. So, and generally these treatments are offered in combination. So you have to kind of figure out where does this fit with something that somebody may already be taking, or does it replace what they're taking? And is this something that we want to use for people who are just starting treatment? Maybe they were just diagnosed, or something that maybe we want to switch people to who are already on treatment. And those are often kind of individual questions. It's not always the same for each person.
Well, it's a personal thing. For you, how, like, in your history, how often have you had to change your drug combinations, if you don't mind me asking you?
Me?
Yeah.
I initially was very reluctant to go on treatment. I went on AZT monotherapy briefly and came to the conclusion that wasn't right for me, so I stopped that. I really got serious about treatment when protease therapy came out.
Yes.
In 1995, and I went on a triple combination of that. The last time I switched treatment, it's been quite a while. I think I've been on the same treatment that I was on when I came to Dr. Vernatter, which is Prozista with what's called a booster, 100 milligrams of Norvir. So I'm on a pretty simple regimen, and I take probably less antiretroviral treatment than just about anyone else I know with HIV. What a person takes is, it's a function of what mutations they might have, what treatments will work for them, what they've taken before, their tolerance, their lifestyle issues as well. If somebody's homeless, they can't very well have a treatment that requires refrigeration, for example. But today there are so many different treatments, and they can really be customized to the various things going on in your body, and the side effects are pretty minimal. I don't feel any side effects from my treatment, and I'm somebody who spent years writing about side effects and how awful they were. I know everything about it, but it just really, if anybody's having significant side effects from their HIV treatment today, they might talk to their doctor about finding something that was less bothersome for them.
Really, really good point. I mean, I've learned so much here today. I have a number of friends from the 80s that have been on, the antivirals. They're doing great, but it's become a subject that, people just want to live their lives, right? They don't want to sit down and talk about this stuff. But being in this community, I find that I want to be able to talk about it. People ask me, I want to be able to give them informed answers. I mean, the two of you are the best tag team ever. You really are, patient and doctor. Do we have some questions?
I haven't really seen any questions come up. So if anybody has any, feel free to pop those up. I just wanted to ask a question myself. I mean, okay, so we're talking about one infectious disease, but I mean, not to make everything about COVID, but of course, it is 20
elephant in the room, right?
Infectious disease. Yeah. And I was curious about, one of you is a mayor and the other is an infectious disease doctor. How has COVID impacted your life and what you do?
You want to go first or should I?
You go ahead.
Okay. Well, there are a few ways. One is it's become a thing that every time someone turns up with an infection, you have to think about, is it COVID? But there was a point where it was a big strain on hospital resources, and I was still at the hospital in March, April, May, June. That was at one point almost all we had, just because the hospitals were full, and they're having that now in some places in the Midwest. Yeah. And it got to be exhausting. Then there's the obvious of everyone. Well, what precautions now do I have to take to make sure that I'm not? And I think even at the doctor's office, you have to think about things like, well, how many people are going to be in the waiting room? Maybe we should space visits out so that we only have one person in the waiting room at a time, just in case. And all these sort of considerations that we can have before.
And first of all, just on a personal level, right? Anybody immune compromised who has a health condition, you have that sort of concern for the people in our lives. In my case, concern at the business, our guests and our employees.
Yeah.
But I think that because of my experience with the epidemic, I was maybe paying a little more attention than I might have otherwise in February when the news really started to hit. And it's fortunate that we have a public safety council that's several borough council members and a couple of others, including an infectious disease doc, my sister Megan's partner, Dr. Doug Mannion. And we made a decision that was not an easy decision to make at the time, to recommend that businesses shut down or cut back and people stay in their home and avoid unnecessary travel. We were the first municipality in Pennsylvania to do that. We did it a week before the state did. We did it at a time where people like saying, what do you mean shut down? And, and some businesses were pretty upset with us. And then Dr. Mannion and I started, we were on the radio 4 times a week. We're still on once a week. We started the Facebook page, has 2,500 people, Milford COVID Volunteer Task Force. And we started the Milford COVID Relief Fund, which is, probably over 100 people have donated to it. And we provide sanitation supplies without charge to any business in Milford and to nonprofits all over the county. So we just began a really, kind of proactive response when, we were advocating masks, and I was writing a letter to Dr. Levine, Pennsylvania Secretary of Health, saying, what is going on? Why can't you recommend masks? Who cares what the CDC says? They don't know what they're talking about anyway. So we were way out there. And that has benefited Pike County. We have consistently been significantly lower in transmission than most of our peer counties and the counties around us. Until a couple weeks ago, we were had the third lowest rate of transmission of any county in Pennsylvania. And I really think that that's because of the leadership. Our county got involved early. The people who really were willing to step out there and say, this is important. Because look, we're a county, our primary private sector economy is tourism. That's what drives it. It's visitation. People from other places coming here. We have the highest percentage of weekend or seasonal homes of any county in Pennsylvania. Those are people from elsewhere coming here. We really don't have many jobs in this county. So the people who live here go to northern New Jersey, they go to New York to work. So we have tremendous amount of back and forth with other areas. So, by all rights, by those measures, you think, my gosh, this place would be just crazy with virus. But, we were running one of the lowest in the country. I said we were the third lowest of the two counties with the lower rate of transmission. One of them hasn't had any.
Oh, wow.
Because it's Cameron County and all they have is elk. But what happened in the last several weeks, a combination of it getting colder, people going back inside, people just letting down their guard. We all get sick and tired of this. Some of the political events, where people were not masked, were not adequately distanced. Halloween probably, did some of this. All these things kind of came together, and boy, we're booming now. We are booming now with a tremendous amount of transmission. One of the measures that's typically used, two of them. One is the number of cases in any 14-day period, the last 14 days, the number of cases per 100,000 people. And we had that down in single digits. So we had very, very little transmission. This summer we were trying to get it down below 50 because that was the threshold when some of the stores could go to yellow and green or whatever it was. Right now I didn't look today, but it's like at 170. It's way, 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 way up there. Literally, what is that, like 50 or 60 times, maybe 40 times the rate of transmission of just a few weeks ago. Another measure is the percentage of people who get tested, the percentage of those tests that are positive. Now, we have very poor testing infrastructure in Pennsylvania. We have not ramped up testing the way New York has. New York's done a really amazing job of that, but here we don't. But our percentage of positive tests, had been running 2%, 3%, maybe it'd bump up to 4% and then come back down. And now it's running over 10% of our tests of people getting testing positive. The thing about it is, though, we can bring that down. That's not all bad news. The good news is that literally, if people do this, we know the things that bring it down. If we ever just kind of cut back for a couple of weeks, those cases that are out there percolating would get identified and they could be, isolated and treated and dealt with. We can bring it back down. And if we don't act now, and every day, you're seeing what's happening nationally, right? There's huge, it becomes exponential. So every day we're not doing that in Pike County is a day that it's getting a lot worse. Now, I will tell you, 2 weeks ago, Xavier and I drove down to Carbon County, Pennsylvania, to Jim Thorpe, which is a charming borough. Yeah. Mm-hmm. And we were astonished at how many people in the streets and the stores and the restaurants were not wearing masks. Yeah. And their transmission rate is vastly higher than ours, So we're pretty lucky is that around here, I would say the restaurants in Milford, they're all being very, very good about it. And I know with some of the patrons of the restaurant, even at ours, a lot of them were resistant at first. But then they start to understand that nice young woman waiting on them is wearing a mask and is asking you to wear a mask. And instead of getting mad at her, maybe you might understand that she lives with her grandmother, who's diabetic and really ill. And she's terrified, she's working to be able to help contribute to pay that for that household, but terrified that she's going to bring home a bug that'll kill her grandmother. So I always tell people, keep that in mind, when you're saying, I won't, I'm healthy, or it won't be so bad, or I knew somebody who got it and they were fine for a couple of weeks, and they don't want to wear a mask. Well, think about the person in that restaurant or that store that you're potentially putting at risk because most people who have COVID don't have symptoms and they don't know it and they're spreading it.
So I have a question. This summer, I was talking to an infectious disease doctor, and I want both of you to weigh in on this. He said to me with his HIV patients that he found that they were not getting COVID even if their partner had gotten it. And he was, and this is just, we were talking, he was attributing it to the antiviral drugs that a lot of his patients were on. What do you both think about that?
Well, so I'll jump in. So interestingly enough, it does seem that at the very least, people with HIV are no more likely to have a bad case of COVID than people without HIV. And there have been a number of explanations proposed for that, including maybe the HIV treatments were somehow protective.
Interesting.
We really don't know yet.
Yeah.
Still, I will say that I have seen people with HIV on treatment get COVID and in some cases get critically ill. So it's I don't want anyone to think, well, I'm on HIV treatment, therefore I'm in the clear. But whereas a lot of things, influenza, pneumonia, people with HIV tend to have worse outcomes for whatever reason. So far, that doesn't seem to be the case with COVID.
Interesting.
And I've got a sort of a thought on that as well. I don't know if I'm echoing or if that's echoing somewhere else, but I'm getting a feedback. I've seen some of these articles that suggest, as Dr. Vernatter said, that maybe people with HIV on treatment, might be less likely to get it, or might be less likely to get as sick, or something like that. But to the extent that we're talking about people with HIV, a lot of us, our consciousness is so heightened around infectious disease and pandemics. If you look at the advocacy response around COVID, all sorts of groups, it's a huge number of people who came out of AIDS activism. A huge number of people with HIV are in the forefront of community responses to COVID, because we know what it's like to have a virus going through a community that we don't know enough about, that's frightening. We're not entirely sure how it's spread, and with governmental leadership that is indifferent at best, here with COVID, they're calling it herd mentality, the Trump administration strategy. When Ronald Reagan was president, it was the phrases were, well, it's nature cleaning house. Let's just let nature take its course. It's nature cleaning house in terms of who it's getting rid of. So, a lot of us have been sensitized to that. And I find that my friends who've kind of been through that experience are much more diligent about distancing and masks and hand washing and being conscious of it, because they've lived it in such a real way. There's absolutely no research to support that at all, other than my anecdotal observation. But I've wondered if that wasn't something related to what might be a lower rate or better response in people with HIV.
I think that makes as much sense as any explanation I've heard.
I was about to say, it just seems like common sense. Yeah. People that know better do better, So thank you both so much.
Wait.
But no, we're not going off yet, because this is the plug time. So Before we go, Sean and Dr. Joshua, any last plugs, any last things you want to tell everyone?
Well, all right. I'll tell everyone, I'm obviously, Dr. Vernatter said that I flattered him, so maybe I am a little bit, but I'm obviously a fan. And I think if anybody has questions about HIV, he's very generous with his insights and his time, and is a skilled doctor. And he's right here, and he's part of our community, and willing to participate and do something like this with TriVersity. And I think that's something we should celebrate and treasure and take advantage of. So if somebody is listening to this either today or watching it later when it's online, use that email and reach out and make your friends some help for what you're looking for.
And Dr. Doctor, he might have done your plug for you.
Thank you very much.
Thank you very much for being here. For our audience, Sean's book, Body Counts, great book. Probably one of the most honest books I've read about what happened in the years of HIV and AIDS. And from a highly personal point of view, I cried and I also laughed because that's life, right? So really great book. It's on Amazon where everything else is. So Body Counts, a memoir of politics, sex, AIDS, and survival.
And we have a link here to Sean's website, seanstrub.com, where I imagine you could find more information about body counts. My Friend the Mayor, though there is a website for My Friend the Mayor as well, for the documentary about HIV criminalization. I'm sure you can find all of this there.
Yep.
And once again, and finally, if you are watching this for the first time and you are HIV positive, we do offer a support group at TriVersity. We don't give out a ton of information about it unless you inquire, because we want to keep people confidentiality and anonymity. But please reach out to us at support@TriVersityCenter.org. That is right below here, support@TriVersityCenter.org. And we will get back to you and connect you with our facilitator. So I guess, Wendy, is there anything else for tonight?
Well, I guess this is going to be good night. This was a terrific show. It was everything that we love to do. We advocate, we educate, and we entertain, because we believe that is a great way to get information to people. Thank you both. You're both so busy, and the fact that you took your time to be with Stephen and myself tonight means everything.
We really appreciate doing this program and all the work that TriVersity is doing. These Zoom programs have been great.
Thank you. Thank you both so much.
StreamYard or whatever they are.
Yeah, I know what you're
Same difference.
Zoom, StreamYard.
Okay. Good night, everyone.
Good night, everyone.
Good night.